and how it develops in the body. You don't have a course on histology or embryology, and I'm certainly not going to try to give you an embryological lecture, but I'm going to talk a bit about how bone and cartilage arise, what they're composed of, and some sort of basic science background. If you go into a medical school anywhere in the country today, you won't be able to find a department of anatomy. All the departments of anatomy sort of went away in the late, well, probably in the mid-90s. And that is because they found all the parts, you know. Gross anatomy, they already know where all the parts are, and you can kind of figure it out on, you can look at them on a computer and learn gross anatomy. They all became departments of cell biology. And that's because all the new knowledge that used to be sort of looked at in anatomy departments are now looked at in cell biology departments. We're going to be talking more about cell biology today than anything else, but we're not going to get very deep in the weeds. So I'm just going to try to cover the big ideas. I think if you use these slides and you learn everything that I've got on these slides and the concepts behind them, you'll have no trouble with the exam questions over this hour next Monday. So if anything comes to your mind that doesn't sound quite right or is confusing, just raise your hand and I'll see if I can answer it. So the stuff we're going to be talking about in this hour is the connective tissue. And the connective tissue basically all comes from the mesenchymal cell. The mesenchyme is a stuff in the embryo that develops into these 5 things: the muscle cells, the fat cells, the bone cells, the fibroblast, which is the early cell that, stem cell really, a stem cell that develops what we think of as the connective tissue, and the chondroblast, which is the cell that becomes cartilage. These are the things we're going to be trying to wrap our minds around. But this is maybe as much as anything a vocabulary lesson, and so I'm going to use the words that I think are the most important to try to get an idea of what's going on in bone and cartilage development. And I'm leaving out 10,000 times more words than I'm using. But I don't think as a practitioner you need to worry about them much. If it ever comes up that you need to know it, it'll take you very little time to teach it to yourself. Especially if you have a really strong need to know it. You won't have much of a need to know it practicing medicine. Okay, so the fibroblast, one of those 5 cells that comes out of the mesenchymal stem cell, secretes all the components, basically, of connective tissue. So connective tissue, as I've told you several times before, clinical medicine is difficult sometimes because some of the words are ambiguous. Connective tissue is one of those ambiguous terms. You see in textbooks sometimes connective tissue diseases. There are some things that maybe you could call a connective tissue disease. Most of them have turned out to be autoimmune in nature. But what is connective tissue? It's the tissue that connects, supports, binds, or separates other tissues or organs. It's really the stuff between the cells in the extracellular fluid space, in the extracellular space. So nothing inside the cell is connective tissue. It's all outside the cell, okay? There are some cells, but very few, embedded in this substance, often with collagen or other fibers, and including cartilaginous, fatty, and elastic tissues. Ambiguous terms, what does that mean? What does that look like? Collagen, as it turns out, is the most abundant protein in the body. And it contains the lion's share. The lion's share of connective tissue is collagen. Proteoglycans is one of the words I want you to remember. It's a precursor muscle or precursor molecule of collagen. And it's secreted by the fibroblasts. Proteoglycans bind collagen fibers, elastic fibers, and reticular fibers. It binds them together. It's like little threads that take these collagen fibers and wrap them into something that becomes a fiber. It's like a rope made up of small threads or fibers. Elastic fibers predominate in blood vessels and ligaments. This makes some sense because elastic fibers are stretchy, and we know that blood vessels dilate and contract. We know that ligaments have to have the ability to take tension and stretch a little bit. Reticular fibers, you don't need to know much more about, except that they predominate in lymphatic tissue and in basement membranes. You don't really need to know how to identify them. You're never going to see a fiber unless you practice with a microscope in your hand, which I've never seen a PA do. Now, there are some fiber-related diseases. These are some diseases that, in fact, are related to the fibers in connective tissue. Scurvy is a lack of vitamin C. You will probably never see scurvy. I've seen one case. Why is it that you will never see scurvy? Because what?
Because we put vitamin C in everything.
Put vitamin C in basically everything. I mean, it's really hard to eat a diet deficient in vitamin C. It was a disease that was noticed by English sailors. And when they would get out on the sea for months on end and run out of food or not have any fresh vegetables, they would get scurvy. And I've seen one case of scurvy. It was the damnedest thing I've ever seen. I went into check-in rounds one morning, and my intern said, I admitted this lady whose legs are bleeding, and I've examined her, taken her history, I examined her. She has perifollicular hemorrhage, and I think she has scurvy. I looked at her as if she were from Mars. I said, well, she doesn't. She lives half a mile from the Health Sciences Center. She said, no, I'm telling you, she's got scurvy. I'm telling you. She's had nothing to eat for the past 5 years except oatmeal. I doubt that. Let's go see her. So I walk in the room and I introduce myself and I say to this lady, what's going on? Well, my legs are bleeding. So she says, I was here 5 years ago and I had abdominal pain. They told me I had an ulcer. And that won't be the last time I kick that. I had an ulcer, and the doctor came in and said, eat a bland diet. So I went home, and I've been eating a bland diet. What do you eat? She said, oatmeal. I said, what else do you eat? She said, I don't eat anything else. That's the damnest thing I've ever seen. She didn't. She wasn't lying. She just said, I just eat a bland diet. I just eat oatmeal 3 times a day. And so I pull up the sheets, and there's her legs, and she's got these little hemorrhagic lesions around hair follicles on her lower extremities. It's the prototypic lesion of scurvy, bleeding along hair follicles in the skin. She had all kinds of other things. We did all the biochemical tests, and sure enough, she had scurvy. Did the doctor really mean eat a bland diet? Well, I mean, that's probably adherence to the max right there. She is a 72-year-old compliant female. Right? Okay, so Ehlers-Danlos syndrome is a disease of tropocollagen, and if you don't quite get what Ehlers-Danlos syndrome is, go to the internet and just type in Ehlers-Danlos and put in picture. And it'll give you a picture of a little kid who basically is so flexible that you could wrap him up and roll him up into a little bundle. The bones are soft and the joints are lax, and it's really pitiful. People with Ehlers-Danlos syndrome can have full-blown or they can have mild, but it's a disease of fiber. Osteogenesis imperfecti, point mutation in a collagen gene, and it's a, so on pants, they'll probably ask you two things about osteogenic imperfecti. One is it is a problem with type 1 collagen. You need to associate type 1 collagen with osteogenesis imperfecti. And you need to remember blue sclera. There's a child with osteogenesis imperfecti, and she has blue sclera. Everyone appreciate the blueness? The sclera are blue in osteogenesis imperfecta because the sclera are so thin. They're so thin. The sclera are blue for the same reason the sky is blue. Why is the sky blue?
It's reflective.
It's the color what?
That our eyes take in, reflected.
Because it's the color our eyes see. That's good.
You know what I meant.
The way,
No. Why is that the color our eyes see?
It's
the
reflective.
way the
wavelength
light
of light.
reflects. The way the light is reflected.
Partly. The light is reflected. What light are we talking about? Sunlight. So the sunlight's beaming down on the earth. The earth is surrounded by atmosphere. When that light hits the atmosphere, two things happen. Some of it's reflected back. Some of it comes through, bent, like it's coming through a lens. And it so happens that the content of the atmosphere is such that it's the blue light that we see. It's the blue rays that predominate, and that's why the blue sky is there. So with blue sclera, what's happening is, with normal sclera, incident light is coming in, being reflected back, and it's the, some is refracted and sent through, some is reflected back. In most normal sclera, white is what's reflected back to us. This is so thin that blue gets reflected back to us. That's the only use I've ever made of my physics degree from undergraduate school, except for this one. If you examine a patient who's laying on the table and you describe their veins, what color are they? What? They're green? Oh, blue. Bluish green? Blue? Greenish? Okay. So they're somewhere in that blue-green thing. But if you stick a needle in there and suck out that liquid that's in it, what's it going to be? Red. Why don't they look red?
Oxygen.
Same reason that the sky's blue, same reason these sclera are blue. The vessel wall is such that it reflects back blue rays, blue wavelengths to our retina. Okay, so two things to remember about osteogenesis imperfecta: blue sclera and type 1 collagen. Goodpasture syndrome is now no longer called Goodpasture syndrome. It's a vasculitis. But it is an autoantibody disease to type 4 collagen. Now, PANTS exam may well call it Goodpastures. They may not have caught up with the current terminology of one of the vasculitides, but we'll talk about the vasculitides of Goodpastures on Thursday. And then Marfan Syndrome. It's a defect in fibrillin 1 gene. So when you think of Marfan Syndrome, there are 4 things you want to remember. It's a defect in a fibrillin 1 gene. These people are tall. They have a high arched palate. They have myopia because they have an abnormal lens in their eye. And they have mitral valve prolapse. Now, not all people with Marfan's have all of these findings, but these are the ones that will probably show up on an exam. Now, the thing that is commonly taught about Marfan syndrome is that if you measure their wingspan, it's always longer than their height. If that's true, about half the NBA players have Marfan syndrome, and that's probably not true. It's probably not true that half the NBA players have Marfan's, but you hear them announcing on the TV all the time. This guy's got a wingspan. This guy's got 7'5" wingspan. He's about 6'8", right? Well, he doesn't have Marfan syndrome. So that's not a marker, but it's a common finding. They have a long wingspan, arched palate, big arched palate. They can have aortic insufficiency and mitral valve prolapse. They have a systolic click on physical exam. How do you determine a click? Remember what a click is? Kinda, sorta, maybe. Okay, so here's a pearl. What's the difference between a click and a gallop?
The rhythm.
All the gallops are in diastole, right? All the clicks are in systole. They're discrete sounds. So if you have your stethoscope on a chest and you hear S1 and S2, it's a discrete sound. Dot, 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 dot. If you hear any discrete sound outside the systolic space, it's in diastole, it's a gallop. S3 is right after S2, and S4 is right before S1. Those are early diastolic and late diastolic gallops. If you hear a discrete sound inside of systole, it's a click. A discrete sound, not a shh. That's a murmur. Shh is a murmur. Is a discrete sound. Okay? And a systolic click is the diagnostic finding for mitral valve prolapse. It's a really wonderful thing you can diagnose on physical exam, because if you hear that click, then what you do is you have the patient squat and listen to them carefully while they're squatted down there. Hear the click, and then have them raise up. And that click moves later in systole. So you can make the diagnosis on physical exam if you pay close attention and get to where you can listen to these things. Tall stature, wide wingspan, high arched palate, myopia, and mitral valve prolapse. Okay, here's another X-ray of a child with osteogenesis imperfecta. The bones are so weak that you can just bend them around. It's not good. Okay, now we're going to talk about some really boring stuff. Boring to me. Collagen production. Collagen is produced by the chondroblast and the chondrocyte, which are the cells that generate cartilage. Okay? Chondroblast, which is a stem cell, is matured into a chondrocyte. Chondrocyte makes tropocollagen. It's a 3 alpha strand protein arranged in an alpha helix. So it's like 3 alpha proteins that are twisted into a rope-like structure. And there are at least 29 different kinds. As I said earlier, collagen is the most common protein in the human body. protocollagen is just the early collagen molecule. There's your triple helix down here, okay? And it's produced, by and large, it's produced by fibroblast. Remember the cell line there, it's the fibroblast which is producing most of the stuff in the connective tissue. So these tropocollagen molecules overlap into collagen fibrils. These fibrils are bound together to form fibers, which are bound together to make more mature structures like ligaments and tendons. So it's really just a matter of terminology. Tropocollagen, collagen, fibers, fibrils, fibers, tendons, ligaments. And these things mostly get developed from early days of the embryo to birth, and the babies are born with all of these structures in place, but they're not yet fully mature, which is why they can't stand up. They can't crawl. They have to. This musculoskeletal system has to mature over the first year to get strong enough and enough coordination to get up and walk. Okay, the extracellular matrix. Turns out that if you analyze the extracellular matrix in the brain, it'll be different than if you analyze the extracellular matrix in the muscles of the leg or the heart or the lungs. It'll all be different because they evolve independent of one another, and so they have different content. But the function of this extracellular matrix is the same in all the systems, okay? They allow adhesion of all the cells. So it's why the cells of the heart don't just sort of fall apart or dissolve away. They're all connected, if you will, connected by this extracellular matrix, by this connective tissue. They provide the ability for cells to communicate with one another, which they do all the time. We're running more and more cell signaling where cells are talking to one another biochemically all the time. And they have within their extracellular matrix mesenchymal cells that can differentiate into whatever system they're in. So the whole idea of using stem cells to regenerate spinal cords or regenerate myocardial cells or regenerate other cells that have gone haywire in the body is a big part of science today. Trying to figure out if we can use fetal stem cells to grow new tissue. Differentiation. Okay, so how does cartilage form? Chondroblast develops into a chondrocyte. Chondrocyte secretes extracellular matrix. It's mostly aggregan, that's a protein, and collagen type 2. All of this protein is negatively charged, and so it holds water. So cartilage has a lot of water in it. Now, collagen growth from this early business of making aggregan and collagen type 2 is just basically a waiting process for early young collagen to mature into older collagen. There's really not much else to say about it. It takes time, it takes maturation, and if you're like me, you don't really care. You just know where the cartilage is and what it does, and you know how to diagnose it, and all the rest of it is cell biology. And if you really want to know the cell biology, you should go to graduate school and study cell biology. And don't call me and tell me anything about it. So articular cartilage is the cartilage at the end of long bones. Right? It's the cartilage that we're aware of. It's the cartilage that Sally was talking about today when she was showing you how to examine the cartilage of the knee, the cartilage of the shoulder and elbow. These are collagen covering the ends of long bones. Now, the three things that we need to know about collagen is repair is limited. So when you rip your collagen, or you rip your cartilage in a football game or a skiing accident, it does not repair well on its own. You can sometimes get by without having surgery by just not injuring it anymore. But sometimes you have to have surgery and have it sort of sewed back together. It doesn't repair well on its own. Nutrition is supplied by diffusion, and it's not highly nutritious. And there's very slow turnover in the extracellular matrix of cartilage. That's probably why it doesn't repair well. There's not much turnover. So it's not a substance in the body you want to be doing injury to much. Now this is a slide that the only thing I want you to know about this slide, don't worry about all that stuff over on the right. I just want you to know that there are three kinds: hyaline, elastic, and fibrocartilage. Just be familiar with those terms. If you need to know anything else about them, you can look them up. But it's not going to help you or help me to go into much in detail, okay? So let's talk about osteoarthritis. This is a real pathophysiology slide. So osteoarthritis, we commonly call wear and tear arthritis. Clinicians, if you ask a clinician, what is osteoarthritis? They'll say, oh, you know, that's the wear and tear arthritis. What do you mean by that? Well, that's what you get when you get older. And that's kind of true. It's the consequence of biochemical and biomechanical processes involved in cartilage, synovium, bone, and soft tissues surrounding the joint. A lot of things can cause it. Injury can make it come on earlier in life. Family history of a lot of osteoarthritis can cause it to come on. It can be repeated microtrauma, such as typing on a computer. Genetic, metabolic, systemic. That's an interesting way to spell systemic. That's from the Panhandle of Oklahoma, we spell it. So the thing to remember about osteoarthritis is that when it's progressing, it's being caused by metalloproteinases. That's a word you need to remember. Metalloproteinases. And these are enzymes produced by the chondrocyte. This is a difficult, counterintuitive concept. Metalloproteinases are produced by the osteocyte. I don't mean the osteocyte, the chondrocyte. The chondrocyte also builds cartilage. It also secretes the proteins that tear it down. It's a duplicitous cell. It does both. Builds it up, tears it down. Inappropriately low levels of tissue inhibitors of metalloproteinases can reduce the ability of cartilage to resist. So what we've got here is we've got chondrocytes making MMPs, and we've got some other cell making inhibitors of MMPs. And so all the time, the body's in there trying to build cartilage and tear cartilage down, build cartilage and tear cartilage down. And so this slide sort of describes that. You've got, if you're talking about cartilage remodeling, it doesn't remodel much, but when it does, it's because you have, when it's building up, you have increase in matrix synthesis. You've got fibroblasts laying down this matrix. And you have a decrease in the ratio of protease, which is the MMP, to inhibitor of MMP. And just the opposite causes a decrease in the amount of cartilage. So this is sort of a, I would call it a concept that is counterintuitive. The same cell in the body seems to be building cartilage and tearing it down. Here's a radiograph of osteoarthritis of the hip. And So there are several things about osteoarthritis of the hip that we want to talk, or of any joint that we want to talk about. Here is supposed to be the joint line right here. This is the head of the femur, and this is the ischium. And the keynotes of an X-ray with osteoarthritis is narrowing of joint space. The joint space is narrowed because the cartilage, the articular cartilage, is gone. So the bone, you've heard your grandmother say, oh, you know, my hip hurts. Doc says it's just bone on bone. It's bone on bone because there ain't no cartilage. Okay? And there's very little joint space in here because of that. An intermittent. Okay. Now what happens when you get this bone on bone, the bone responds by trying to build bone. It's an injury, and it responds by trying to build bone. We're getting ready to talk about modeling and remodeling of bone, but what happens on both sides is called subchondral. Subchondral means just below where the cartilage was. Chondral means cartilage. Subcartilage or subchondral sclerosis. Sclerosis is a term which means very dense bone, very, very dense bone. And this is a response to this bone-on-bone abnormality. Is that clear? So the two findings on X-ray of osteoarthritis are narrowing of the joint space and subchondral sclerosis. Okay? That's all I'm going to say about cartilage, because that's all I know about cartilage. I once had when I was chief medical resident, I had a party for my third year medical, or my senior students who I'd spent a lot of time with when they were MS3s. And I had them at the bar, and I was buying beer for them, and this guy who I still see periodically around town came up and was all excited. He said, oh, banana. God, I got matched in orthopedics. I got matched in orthopedics, he says. And I stood back and frowned and said, I don't shake hands with biocarpenters. He still reminds me of that comment. I don't feel very proud of it, but you know, I was young, an asshole. What can I say? Okay, bone formation. The mesenchymal stem cell matures into the osteoblast. Okay? The osteoblast is one of the two most important cells in bone formation. Now, here's a really important issue. Osteoclast, C-L-A-S-T, is the other cell that's most important in bone formation and remodeling. And what's really interesting is that it wasn't until about, I don't know, 1987 or 1990 that we figured out, or someone, I don't want to say we, I didn't have anything to do with it, that someone figured out that the osteoclast comes directly out of the bone marrow. It comes from the monocyte cell line. The monocyte cell line, remember, is the cell line that gives us macrophages. And so this is a really important cell line when it comes to the immune system. It's a really important cell line when it comes to fighting infection. But it also gives us the osteoclast. Why that is totally beyond me. But the osteoclast comes from a different cell line than the osteoblast. Okay, there are two kinds of bone growth. Now, I can't imagine that the pants would have anything on it about bone growth. unless maybe it's fancying itself something about pediatrics, you know, because kids are growing and when they grow, their bones are getting longer. Most of the length of bone growth is done by endochondral bone. And endochondral bone growth is bone growth that grows on a cartilaginous template. Membranous bone growth has no cartilage template. That's really the biggest thing you need to remember. Endochondral bone growth is bone growth that grows on a cartilaginous template. I'm going to show you a cartoon of that here in a minute. You commonly see people say there's a osteoclast chase and a chondrocyte run in endochondral bone growth. And I'm going to try to demonstrate that. Here's a cartoon that tries to demonstrate. Up here, you have chondrocytes. You have an osteogenic ossification front here, and below it, you have osteoclasts and osteoblasts. So when the bone is growing using this kind of bone growth, you've got osteoclasts eating away these chondrocytes and making the marrow bigger. And you've got osteoblasts, you've got chondrocytes running from it, okay? So chondrocytes are up here laying down new cartilage in this young bone. You got osteoclasts coming by eating it, and you got osteoblasts, which are demonstrated over here on the left side. You have osteoblasts coming behind it in the osteoid, laying down new bone and mineralizing. This is chondral bone growth. Okay, now this is a cartoon, and I'm going to point out 2 or 3 things that you need to remember from this, okay? This is the Haversian system of the osteon. So this is a cartoon of how the bone is structured, a mature bone is structured. And what you see is that it has arteries coming up in the middle of these circles. The circles are Haversian systems for osteons, okay? These little squares in here are osteocytes. They are bone cells that are creating new bone, osteocytes. Okay? Now, the thing that's not shown on this cartoon, but is very important for you to know, is that these osteocytes between these blood vessels receive their nutrition because the osteocytes have cell processes that communicate with each other. So the center ones are connected to the ones that to their side, or connected to the ones to their side, or connected to the ones to their side. And nutrition diffuses into this bone space from these arteries. It's not necessarily a capillary system like we have everywhere else in the body, but nutrition diffuses out of these arteries or arterioles in the middle of the Haversian system, or osteon, and give the osteocytes their nutrition. Okay? You also need to know how the Haversian system, or the osteon, is structured. Those are the 2 main things I want you to know from this diagram. Now, this is called spongy bone, but you don't have to worry about whether or not something's spongy or not spongy. It's too much. It's too much. We'll let the biocarpenters worry about that. They don't know it either. All they want to know is how to fix a broken bone. They don't want to know about this. Cell biology, I guarantee you. First rotation, you want to know all those things that Sally told you this morning, and nothing that I'm going to tell you. Don't ask those orthopedic surgeons anything that I'm telling you. They'll look at you like you're weird. Okay, so this is a cartoon that defines some of the things we need to know about bone. The metaphysis is an area of bone toward the end of the long bone surrounding the epiphyseal plate. The epiphyseal plate is the plate that Scott talked about yesterday when he talked about those 5 types of epiphyseal fractures in children. Right? You need to review that from his handout. And this is this plate he's talking about. Some of those fractures are above the plate, some are below the plate, some are straight line through the plate, some are crushed the plate. You just need to know that stuff. Okay, this is a cartoon that you only have to know 3 things about this cartoon. The first is, here is the osteoblast, and it is creating a signaling system called RANKL, R-A-N-K-L. You don't have to know what RANKL stands for. You just have to know that the osteoblast, as a cell in the bone, uses RANKL to turn on the macrophage and turn them into an osteoclast. Here's the cell coming out of the bone marrow, the macrocytic cell. When it gets here, the osteoblast sends a signal to turn it into an osteoclast. So the cell that builds bone turns on a signal to a cell that tears down bone. This is also a little bit counterintuitive, but it's I suppose a process that has developed over time such that we can remodel bone. We can heal a bone that's broken, and we can remodel it over time so that our bones don't give away before our heart does. That's how I see it. This remodeling system is a way for our skeletal system to constantly turn over and remodel itself. It's also the way it heals itself when a bone is broken. Okay? Osteoblast, RANKL, osteoclast. That simplifies that picture a little bit, but it gives you an idea of what's on there. Intramembranous bone growth is bone that just grows by mineralizing the matrix. Connective tissue basement membranes just develop into bone. It's important in the way the skull develops, and it's important in fractured bones, intramembranous. That's really the only two places in which it's really. I think there's some intramembranous bone growth when long bones are getting fatter and when they're growing tall, but mostly it's when the skull is developing in vitro or in the fetus, and when you heal a fracture. And the mechanism is that this MSC is mesangial stem cell develops into an osteoblast and into osteocytes and secrete type 1 collagen. They just secrete type 1 collagen and lays it down in the matrix and bone grows. Okay. Number one thing to remember are 2 ways for bone to grow. And then you ought to be able to develop in your head a little bit of a story about how that works. So secrete type 1 collagen into this matrix, and then it gets mineralized. Now let's talk a little bit about mineralization. Mineralization of the bone is important because 50 to 70% of the content by weight of bone is mineral. What do we mean by mineral? We mean calcium, inorganic phosphate, pyrophosphate, magnesium, potassium, hydroxyapatite, among others. I'll come back to that in just a minute, but 20 to 40% is organic matrix, 5 to 10% is water in bone, and less than 3% is lipids. The most important thing here is that the skeleton is a remarkable bank for calcium phosphate. If our body decides it needs calcium, it'll go to the bone and get it. Okay? It'll go to the bone and get it, and it does it remarkably efficiently. So let's talk a little bit about this process. So mineralization, Pi is inorganic phosphate, inorganic phosphorus atoms. PPI is pyrophosphate. Pyrophosphate is 2 phosphate atoms, and there's a lot of it in the extracellular fluid space. When the extracellular fluid space increases its pyrophosphate, it leads to a decrease in hydroxyapatite. You can think of hydroxyapatite as being the molecule where the calcium and phosphorus are stored in the bone. Okay? And when there's a decrease in this PPI in the extracellular fluid space, there's an increase of it, you'll have a decrease in hydroxyapatite. When there's a decrease in the PPI, you'll have an increase in it. So it's a storage unit for phosphorus and for calcium, and the body will go get it if needed. Now, the body's much better at going to get calcium than it is to go in and get phosphorus. Not quite sure exactly what it is, but it's true. The body's really good at going and getting calcium because of PTH. We're going to cover PTH and vitamin D in detail in the next module. I'm going to give you some lectures on pathophysiology of parathyroid hormone and thyroid hormone in the next module on vitamin D. Bone remodeling. It's a lifelong process where mature bone tissue is removed from the skeleton, bone resorption, and new bone tissue is formed, ossification. These processes also control the reshaping and replacement of bone following injuries like fractures, but also micro damage. So it is true that the body is such that if you go to bed and just lay there, your bones will resorb. Your bones will resorb. I don't know how long it takes for you to become a puddle. Quite a while, I think. I've seen quite a few people who've been in bed like that. But it doesn't take long for your bones to become weak and brittle. The opposite is also true. That as you age, if you will continue to exercise, put stress on the long bones, that's both lifting weights, walking, swimming, putting stress on the long bones will keep the long bones more healthy. So you'll have less chance of fractures if you age, as you age, if you remain active. Primary hormone is the parathyroid hormone. It's secreted by the parathyroid and regulates calcium. So PTH is, we're going to talk about this again in the intro, but PTH is basically mostly released. The parathyroid hormones, you know where they are. They're right behind the thyroid gland. There are 4 of them, and they sit right behind the thyroid glands here. And they release their hormones when the serum calcium gets low. They also are related to the kidney in a lot of ways. And we'll talk about vitamin D metabolism in the next module. For now, just know that PTH ends up activating osteoclasts, which degrade bone and release calcium. That's really the overarching thing that PTH does. Calcium gets low, PTH goes up. PTH goes to the bone break, turns on the osteoclast break down bones, serum calcium goes out. Okay? Throughout life, bone is being remodeled. It is constantly being torn down by osteoclasts built by osteoblasts. The process is delicate, it's balanced, and there are disease processes that throw this balance off, and we'll talk about that in the next module. Because they're mostly endocrinologic in their organization. All right, now, it's 10 till 2. I'm going to start on the Thursday lecture because the Thursday lecture is longer than 2 hours. So I'm going to give about a third of it in this next hour. If you want to take a 5-minute break, we can do that and come back and start the meeting, okay?